welcome to this International Menopause Society webinar. And the topic of this month's webinar is progestogen, progestin, progesterone, why all the confusion? And I'm delighted to say that we have two excellent speakers who are globally known. And Paul Piette will be the first to give his lecture on what clinicians should know about pharmacodynamics and safety of progestogens, progesterone and progestins. And then Regine Sitruk-Ware. I'm a consultant gynecologist at Imperial College London. I'm president-elect of the International Menopause Society. Paul is a senior research fellow and permanent invited speaker at the International and European Price School and scientific and medical affairs consultant in Brussels in Belgium. And Regine is a reproductive endocrinologist and distinguished scientist at the Population Council. And if I could ask now, Paul, if you could share your slides with us and give the first lecture. Thank you very much.
Thank you, Nick, for this nice introduction. And my topic of today will address following questions: what clinicians should know about pharmacodynamics and safety of progestogens, including progesterone and progestins. That's my financial disclosure slide. And as you may know, I'm a consultant for Besoin Healthcare Global. So the first message is the importance of the nature choice. And as you may know, micronized progesterone has a unique pharmacodynamic and safety profile, but it doesn't depend only on the molecule, but also the route of administration. So progesterone is a fascinating molecule, which was discovered more than 80 years ago by Adolf Butenandt. And the interesting story is that he received a Nobel Prize, but there were other 3 Nobel Prizes involved in the discovery and the use of progesterone in women's health since 1939. So we can state that progesterone is a never-ending story because there are a lot of new indications recently discovered and suggested, and it's a permanent ongoing process. So until 1940, it was not possible to use progesterone in clinical practice because it was so expensive to produce. But in 1940, Russell Marker was able to synthesize this progesterone from a plant steroid source called diarginine and extracted from the roots of a wild Mexican yam. So knowing that this Mexican yam or even present in China or Central Africa, we can extract progesterone. The important message is to know that you can not use progesterone per se for medical use. You need to micronize progesterone and to put it in an oily excipient to get this progesterone bioavailable by the oral route of administration. But what I want to explain is the reason why 2 characteristics are crucial to make your progesterone bioavailable and to be used for menopause hormone therapy, for example. It's the size of the particles. You need to micronize progesterone, and the smaller the particles, the better the bioavailability will be. And that's the reason why you cannot compare all formulations available for micronized progesterone, because the effectiveness will depend on the size of the particles. And secondly, the oil is important because we all know that you can improve bioavailability by the oral route of administration, adding some oil as excipient. So it's important to take into consideration that the molecule micronized progesterone, which is exactly the duplicate of the progesterone produced by the human body, has totally different characteristics to synthetic analogs of progesterone, so named synthetic progestogens or progestins. We all know this table with all available progestogens around the world, but what I want to show you is the unique profile of the natural progesterone and to compare with all the available synthetic progestogens. And there are three big families of progestogens. The first is the 19 nortestosterone derivatives with the first and the second generation of progestogens, so-called estrans and gonans. And later on came into the market progesterone derivatives with dydrogesterone, which is until now often used as a menopause hormone therapy, and medroxyprogesterone acetate, which was the progestogen used in the Women's Health Initiative study, and other, let's say, French discovered progestogen like megestrol acetate or chlormadinone acetate. And last but not least, you have those norpregnants recently available on the market, let's say more than 20 years ago, but more recently than the previous one. And I think that Regine will speak about nesterone, which is the last progestogen now available by transdermal route of administration, also named progesterone acetate. So a lot of progestogen available, but what we have to take into consideration is that progesterone has a chemical and a spatial configuration completely identical to endogenous ovarian hormone. So the source of the raw material is not the factor determining the body identical characteristic of progesterone. For example, both progesterone and dydrogesterone are both from a plant source, but the spatial configuration of the molecule is totally different. So the terminology of body identical conveys meaning of this concept in the best way, instead of unregulated bioidentical terminology, as was suggesting Nick in a publication about 5 years ago. As a consequence, the metabolism and the biological effects of micronized progesterone are completely identical to endogenous progesterone and significantly different from synthetic progestins. We have to know that, in fact, synthetic analogs of progesterone have been developed to make the hormone available by the oral route of administration before the micronization of natural progesterone was discovered in the late 80s. And those synthetic progestins were first developed for the use as contraceptive agent and not for menopause hormone therapy. So many of these compounds, synthetic progestin, bind several receptors, such as glucocorticoid, androgen, and mineralocorticoid receptors, and that may induce some unwanted side effects that we all know, such as acne, weight gain, depression, mood swings, irritability, loss of libido, fluid retention, bloating, breakthrough bleeding, and why not an increase in the breast cancer risk, as it was suggested in the Women's Health Initiative. So it's important to take the tip of the molecule into consideration before looking at all those unwanted side effects that we don't want to see in menopause hormone therapy. What also important to know is that small differences in structure will induce different metabolism and different pharmacological and activities. For example, if you take dydrogesterone, is a truncated molecule, there is a double liaison that you don't have in the progesterone molecule, and the CH3 chain is in a different spatial configuration compared to progesterone. So a more or less identical molecule, but small differences will induce a lot of different pharmacological effects. And that's true also for medroxyprogesterone acetate, the progestogen used in the Women's Health Initiative study, with a side chain here, which is totally different from the mother molecule progesterone. So you cannot compare pharmacological effect of those molecules, even if the formula is very similar. So micronized progesterone also will have different pharmacological activities depending the route of administration. And we know, for example, that if you administrate progesterone by the oral route, progesterone will undergo several successive metabolism steps. First in the gut, because bacteria have a lot of 5-beta reductase activity. In the intestinal wall, 5-alpha reductase activity, and last but not least, there will be an intensive liver first metabolism with 5-beta reductase and formation of 3-alpha and 20-alpha hydroxy progesterone metabolites. As a consequence, and that's important to take into consideration, it's not only progesterone when taken by the oral route of administration, which is the active hormone, but a lot of metabolites will participate to the effectiveness and the pharmacodynamics activities of the progesterone into the body. For example, allopregnanolone and the 5-beta pregnenolone will bind the GABA receptor, but I think that Regine will address all those neuro effects of those metabolites in the next presentation. Also, other active metabolites, such as 5-alpha pregnandione and 5-beta pregnandione, participate to the activity of progesterone. For example, they have some antimitotic activities, which is a positive effect to counteract the effect, the proliferative effect of estradiol in menopause hormone therapy. On the contrary, if you administrate progesterone by the vaginal route of administration, the normal vaginal bacteria seem devoid of any 5-alpha and 5-beta reductase activities. So after the vaginal route of administration, you have only a small increase in allopregnanolone and no change in 5-beta pregnenolone levels. And we can state, based on those observations, that the progesterone activities on the central nervous system are modulated by the route of administration. What's important also to take into consideration is looking at the binding affinity of the progestogens, including the progesterone. But most of the table are not taking into consideration the tissue concentration. So it's both factors, tissue concentration and binding affinity, who will induce different pharmacodynamic effects. For example, progesterone has an anti-androgen weak effect. It binds strongly the mineralocorticoid receptor, and it binds the GABA receptor, and not only allopregnanolone metabolite, but progesterone is also produced in loco into the brain, and explaining why we call progesterone a neurosteroid as well as a sex steroid. On the contrary, drospirenone has no activity on the central nervous system, and dydrogesterone is not an anti-androgenic compound and has no diuretic effect. So the question is, are all those pharmacodynamics activities related to menopause hormone treatment, are they contributing to the effectiveness or the safety in menopause hormone therapy? And certainly the answer is yes. But what I want to focus on this figure is that not only progesterone molecule, but the metabolites will activate several progesterone receptors, the progesterone A, the progesterone B, and even progesterone C receptors. And what's interesting, it's not the classical genomic effect always, but you can have very immediate and very direct, quick effect, because progesterone is able to bind membrane progesterone receptors. So in menopause hormone therapy, probably the major effect of progesterone is to counteract the overproliferation of the endometrial tissue induced by estrogen. But we have to know that progesterone has also an effectiveness in reducing hot flushes via the hypothalamus, and it regulates definitely sleep disturbances in postmenopausal women, as it was first shown by Geraldine Pryor from Vancouver. Interesting also, we have progesterone receptor on the bone, and we know that progesterone stimulates new osteoblasts and increased bone formation. It was interesting to observe that, for example, in perimenopausal women, where there are some luteal phase defect or different in the length of the cycle, meaning a progesterone deficiency, those women are losing bone mass before the onset of menopause. Progesterone has also weak or no glucocorticoid activity, but interestingly for menopause, they bind strongly the mineralocorticoid receptor, so it can regulate the blood pressure in postmenopausal women and at least reduce water retention induced by estrogen. It has a weak anti-androgenic activity, which is interesting because that will induce a neutral metabolic profile and a favorable profile, as it was shown in the Piette trial when they were comparing natural progesterone to MPA. Also, progesterone has a nice anxiolytic effect, but it can be even antidepressant or even anesthetic, depending again of the daily dose and the route of administration. And as it was shown by the group of Michael Schumacher in Paris, there are experimental promising data about the cerebral activity in the prevention of stroke. So I think that Regine will address all the effect of progesterone on the GABA receptors. And we don't have to forget that progesterone, first of all, is regulating bleeding and the menstrual cycle in case of luteal phase defect. So are all those pharmacodynamic characteristics clinically meaningful and for menopause hormone therapy? I think that the answer is yes, because for example, progesterone has a nice tranquilizing effect who can counteract all the unwanted side effects due to hyperestrogenemia when you administrate estrogen in the menopause. It has a nice anti-androgenic effect and also this diuretic effect to counteract water retention or even hypertension induced by estrogen. And last but not least, the neuroprotective effect is certainly a positive effect in menopause hormone therapy. When we were asking the question, is it clinically meaningful? I want to share with you two very recent trials in the US, placebo-controlled study, randomized trial, the KEEPS trial that you all know, where they were using transdermal estradiol at the standard dose or a low dose of conjugated equine estrogen, both in association with cyclic continuous progesterone 200 milligrams, but not only this 200 milligram daily dose, but also the 100 milligram daily dose in continuous combined regimen was shown to improve sleep parameters and to improve quality of life in the recent Replenish trial published by Rogerio Lobo 2 or 3 years ago. So there are nice data showing that estradiol in association with micronized progesterone improve quality of life by improving sleep. And that's a pilot study which was done at the Max Planck Institute in 2008, showing nicely how progesterone as a standalone molecule is able to improve sleep based on objective EEG parameters. And very recently in the Journal of Bone Mineral Research, it was suggested that in postmenopausal women with short sleep, if they have 5 hours or less sleep per night, it can increase the loss of bone mass or the risk of osteoporosis at the hip. So very interesting findings. I was telling you that progesterone is binding strongly the mineralocorticoid receptor, and in clinical practice, we can compare the activity of 200 milligram oral progesterone to 50 milligrams of spironolactone, which is the standard dose as a diuretic, and that you all know based on this well-known activity. What about progesterone and endometrial safety? We know since 1996, published in the JAMA, the Piette trial, that micronized progesterone 200 milligrams a day in a cyclic combined treatment can counteract the effect on conjugated equine estrogen, again, the risk of hyperplasia or adenocarcinoma, and that was in a standard dose of conjugated equine estrogen 0.625 milligram. But most recently, the Replenish study using 100 milligram, half of the dose of progesterone in continuous combined regimen, was also shown to be able to protect the endometrium against the risk of hyperplasia or adenocarcinoma in association with 1 milligram of oral estradiol. So it was nicely summarized in this systematic review by Stute and confirmed by the publication of Eden in Australia in 2017, that progesterone protects efficiently the endometrium at the condition that it's used at least for 12 to 14 days at a dose of 200 milligrams a day, or continuous combined with half of the dose of 100 milligrams per day. In case of intolerance to the oral route of administration, vaginal route of administration of progesterone can be suggested for menopause hormone therapy. And in the study by Ciccinelli in 2005, they were suggesting to use 100 milligrams a day vaginally applied every alternate day. The key message is that you cannot administer progesterone by the transdermal route of administration to protect the endometrium. What about the breast safety? And we all know the results of E3N study, which is an observational study in France in 100,000 women. And it was also very interesting to note that there was a huge difference in the breast cancer risk increase depending the type of progesterone. And you can see that the only group where there was no increase in the breast cancer risk when the treatment was initiated in the 3 years following the onset of menopause, which validate the window of opportunity, you can see that there was no increase in breast cancer risk, which was not the case with most of the synthetic progestins used usually in France, and probably that dihydrogesterone was in between both group of progestogen, so probably a little bit more increasing the risk of breast cancer risk comparing to natural progesterone, but lesser than the other synthetic progestogen. And there was a nice biological plausibility about those findings demonstrated by the group of Bo von Schulz and Daniel Mürkes at Karolinska Institute, where they were showing nicely that if you administrate for 2 months transdermal estradiol in association with micronized progesterone, you don't stimulate the proliferation in the healthy breast tissue of women in comparison with medroxyprogesterone acetate, which increased dramatically the proliferation of the healthy tissue in the breast tissue. And that was perfectly correlated with the gene activation, which is responsible for this increase of the key I67 proliferation marker into the breast tissue. And that is probably my last slide, showing also that looking at the results of the Women Health Initiative study, the major concern was the increase in the venous thromboembolism risk. So what about different progestogens about the VTE risk? And you can see in this publication by Scarabin in Climacteric Journal 2018, that not only the route of administration for estradiol is important to mitigate the risk of VTE, but also the type of progestogen. And the only group of women without any increased risk for VTE risk were the women taking transdermal estradiol in association with micronized progesterone. So the take-home message from this presentation is certainly that one fixed treatment doesn't fit all, and progestogens lead to different and specific PK and pharmacodynamic efficacy and safety profiles. A class effect definitely doesn't exist for micronized progesterone and synthetic progestogens in terms of both their efficacy and their safety when they are used in menopause hormone therapy. Body identical hormones and individualized dosage regimens remain the best choice for the management of clinical symptoms and bleeding. And last but not least, the transdermal or low-dose oral estradiol, in association with micronized progesterone, reduce the risk of venous thromboembolism, stroke, gallbladder disease, with limited impact on the breast when it is administered in the early menopause for a duration of at least 5 to 7 years. So I thank you for your attention.
Paul, thank you very much for that excellent, very clear lecture. Before I introduce Regine once again, if I could just remind people that unfortunately the questions can only be asked through the Q&A button, and then I will relay the questions, as many as I can. There are over 1,000 of you now on this webinar, to the speakers for their responses. And we can only take questions in English at the moment. I'm still working on my Russian. So with that, I'd like to ask Regine if she could share her slides with us now to listen to her lecture on potential new health benefits with progesterone and related progestins in MHT.
Thank you, Nick, very much for this introduction. And I want to thank the organizer for organizing this webinar and inviting me. And as you have heard, this very comprehensive lecture of Professor Piette about the many benefits of progesterone, my role now is to show you more details about the neuro benefits of progesterone and some progestin structurally related to the native hormone. I have no financial relationships to disclose. I'm an employee of the Population Council, a non-profit research organization who succeeded to have progesterone approved by the FDA in a first contraceptive as a one-year vaginal ring 2 years ago, and supported research on myelin repair and stroke. And I received a grant from NICHD from the NIH that partly supported this research. The structure of my talk will be in 4 sections. I'll show you first how related chemical structure to progesterone can act as neurosteroids on the brain. Then I'll show you how progesterone and estrone exert effects on myelin and on stroke models. And then I will address the translation to the clinical indications and conclude for the use in menopausal therapy. As you have heard, in the brain, there are different enzymes that allow the synthesis and the metabolism of progesterone. They are reductase that transform progesterone into 5-alpha dehydroprogesterone. And both these two molecules bind and interact via the progesterone receptor. In addition, after further hydroxylation, it transformed into allopregnanolone, which is the 3-alpha, 5-alpha tetrahydroprogesterone. And allopregnanolone, as you know well, and as Paul has alluded to, interacts with the GABA receptors. And also he mentioned that not all progestin may convert into these tetrahydroderivatives as progesterone does, and or they do not interact with the GABA receptor. We have tested estrone by synthesizing the derivative, which is tetrahydroestrone. And in the laboratory of Professor Jeremy Lambert at the University of Dundee, and in collaboration with Michael Schumacher from INSERM, we have tested how the metabolites of estrone may or may not interact with the GABA receptor. And in his model, where he used neuronal cells isolated and does electrophysiological study, you can see here that with a 100 nanomole dose of tetrahydroprogesterone, allopregnanolone, there is a big response, a significant response. And when the same dose of tetrahydrogesterone has been tested, it's a minimal response that is observed. And if you look at the peak amplitudes of the response, the tetrahydroprogesterone has a very significant response. There is still some significance in the increase with tetrahydrogesterone at the same dose, but small, and increasing 10 times the dose of THNES does not increase the response. So we could conclude from some of these experiments that most of the nesterone activity in the brain acts via the progesterone receptor, as I will show you also in more slides, but not via the GABA receptors. The other aspect that Paul has alluded to about the difference in structure and the different interaction with other steroid receptors are important. And as you know, levonorgestrel, which is mostly used in contraceptive and also for some combination for menopausal therapies, has some androgenic activity via this interaction. And together with Marie-Edith Aublin from INSERM, we showed here that levonorgestrel transactivates strongly the androgen receptor, while nesterone, which has a structure which is 19-nor-progesterone and not 19-nor-testosterone, there was no stimulation and no transactivation of the androgen receptor. In another study that we conducted together with Roberta Brinton in the University of Southern California at that time, she tested using flow cytometry in the hippocampus of ovariectomized female rats, how different progestin will induce cell multiplication and how they will affect the cell cycle. As compared to vehicle, progesterone stimulates some of the cell multiplication in the neuronal cells. Nesterone has a more significant response. Levonorgestrel is not significantly acting, and MPA does not induce any response. And so the conclusion was that the neurogenic response to different clinical progestins will really vary dramatically and can have implication in clinical practice. So what are the different effects of progesterone and nesterone on neuroregeneration in experiments conducted in rodents? So we had a first work together with Michael Schumacher Laboratory, where in vitro studies were conducted testing the replenishment of oligodendrocytes and remyelination after they treated slice of brain with lysolecithin, which is a treatment inducing complete demyelination, or at least significant demyelination. And when progesterone was added to the lysolecithin, there was a restoration of the oligodendroglial cells. Nesterone had a higher response, and NPA has non-significant response. Sorry. So this effect is via the progesterone receptor, and you see here knockout, and I will ask you.
This is where, as a chairman, I would offer my colleague a drink of water. Regine has had a bit of a cold, but thank you for soldiering on with us through this difficulty.
Thank you. So in wild-type animal, the progesterone response is very significant, but in the knockout model, the progesterone does not induce a response. The same is seen in this lysolecithin plus nesterone response in the wild type, not in the PR knockout mice. And when there is an haploinsufficiency, which means a partial content of progesterone receptors, there is still a response, but much less. In other in vivo studies conducted with the same group of Michael Schumacher laboratory with Martine Lettre, we had several experiments testing how, after complete demyelination with a copper chelator, cuprizone, you can see here that the myelin basic protein has decreased considerably after 12 weeks of feeding them with cuprizone. Administration of a dose of 1, 4, 6, or 8 microgram of nesterone for 3 weeks restored the myelin, and the 6 and 8 had not much difference between these two doses and are equivalent to the progesterone at about 10 milligram dose, as in fact, nesterone has a potency which is 100 times more than progesterone. What was interesting and relevant for the menopause is that the myelin basic protein response that is seen with progesterone is the same in intact animal or in ovariectomized animal. So the same response of progesterone after cuprizone demyelination is unchanged. In other model with Rachida Genoun and Michael Schumacher in INSERM in Paris, we tested nesterone at 0.08 milligram per kilogram in mice, and this dose was 100 times less than the progesterone dose, as we know that there is a difference in various markers of the efficacy of nesterone. And the scientists were able to show a decrease in the infarct volume by about 50% in the male mice. And a few years later, a Japanese group repeated experiments and used 10 and 80 microgram per kilogram, which are in fact here it's 80 microgram per kilogram subcutaneously. And they showed the effect persisting up to 30 days. You can see these pictures taken from this paper where the zone of infarct is in white in the control animal, and after the treatment with nesterone, it was decreased by about half. Oh, sorry. Our colleague and friend from the Menopause Society, Gabrielle Murky, has contributed to another paper where they tested desogestrel and drospirenone at much higher doses than what we have tested with nesterone. And they also showed in female ovariectomized mice that the damage of this stroke model, the middle cerebral artery occlusion, was decreased by about 50% in this model of mice. So what would be the possible clinical application? We can see a translation of interest for treatment of men and women in various indications. And however, the trick is how to administer and how to translate the dose from the preclinical experiment to the clinical experiments. There is an FDA guidance which indicate how you should convert according to the weight of the animals, your response, and the weight of humans. And we have used this formula to prepare for a study in multiple sclerosis, as we could, in fact, imagine that this treatment would be effective in decreasing neurodegeneration, increasing myelin regeneration, and these conditions would be mainly the multiple sclerosis, but also Parkinson's disease, amyotrophic lateral sclerosis, Alzheimer's disease, or ischemic damage caused by stroke or traumatic brain injury. And as far as allopregnanolone is concerned, this is the work of Roberta Brinton. she shared this slide with me where this picture shows the degeneration of the brain at the end of evolution of Alzheimer's disease. And when it started with a decline in regenerative capacity, it goes through various stages until severe brain atrophy. And usually the therapeutic intervention is at the time when beta amyloid plaque is detected, which is already rather late. A proposal is to use allopregnanolone as a therapeutic intervention at the time of the beginning in decline of the regenerative capacity to correct the mitochondrial dysfunction and decrease the inflammation to prevent beta amyloid plaque. And she was able to show in mouse models of Alzheimer's disease with various doses tested, she found an optimized dose with chronic administration, resulting in a neurogenesis, reduction in neuroinflammation, and decrease in the beta amyloid burden. And this was correlated with a test showing restoration of learning and memory function. After this experiment, she shifted to the clinical studies and completed a study of dose finding to test the safety of various doses of allopregnanolone. And now she's preparing for an efficacy study after she demonstrated the safety of the effective doses. So to summarize, progesterone and some specific progestin that have a structure very comparable to progesterone, but also are specific to the binding of progesterone and not interact with other receptors, can regulate neurogenic response. And we showed that progesterone and nesterone, but not medroxyprogesterone acetate, can induce positive effect on myelin repair, and this effect act via the progesterone receptor. So we would not be surprised if the result of the Women's Health Initiative showed that MPA had negative effect in neuronal outcomes. So this impact of progesterone on the regenerative capacity of the brain can be translated to the disease models I listed before and has clinical implication also for menopausal therapy and the cognitive function of patients that may start to degenerate after menopause in some susceptible patients. And the first study I mentioned also from our part is to test nesterone in multiple sclerosis patients, and from Roberta Brinton to test allopregnanolone on cognitive function in early Alzheimer's disease. So all progestins are not equal to progesterone, so I will concur with Paul Piette. There is no progestin class effect, not only with regard to side effects, but also to the central nervous system benefits. And progesterone and some specific molecule can favor neuroregeneration. And against the belief that postmenopausal women who are hysterectomized should not receive progesterone, based on the fact that progesterone was essentially used for preventing endometrial proliferation, I think that these women should benefit from progesterone associated to estradiol, even if they have no uterus. So to conclude, I wanted to thank the various organizations who supported our work, my colleagues at the Population Council, and the collaboration we had established at NIH and with various universities who made this work possible. Thank you.
Thank you very much once again for an excellent lecture, and particularly as you were not feeling particularly well today. So thank you so much for joining us and giving us an excellent lecture. So we now have time to address some of the questions, some of the many questions which have been posed to us. We'll try and get through as many as we can. I suppose the first question, and perhaps one of the more controversial ones, is Regine, you mentioned about potentially continuing progesterone even after a woman has had a hysterectomy for the benefits that you have indicated. And this also relates to Paul's talk. We know with the E3N data that with long-term use, even with micronized progesterone, potentially there was a small increased risk of breast cancer in those women using combined therapy. And I think that's one of the reasons why we have some reservation of continuing progesterone, even natural progesterone, when it's not required for endometrial protection. So I wonder whether you or Paul would like to make a comment about that, and whether we actually, need more data before we can talk about the sort of routine continuation of progesterone in hysterectomized women, with or without estrogen, of course.
I think if I start, and I'm sure Paul would answer, and he showed that the risk of breast cancer was less with the progesterone estradiol combination. But I think that if we determine the exact dose that has beneficial effects on the brain, it will be important, because at the moment we know the dose that prevents the endometrial proliferation. We know from other models that it can act on neuroregeneration, but we have to determine which dose of progesterone converting it to allopregnanolone or of another progestin that has demonstrated effect could regenerate or prevent the beta amyloid plaque and help the cognitive function of women, whether they have a uterus or not.
Paul, did you want to?
Yes, I fully agree with the comment of Regine, but I want to do two preliminary remarks. First of all, the E3N study was an observational study. So when you see a relative risk, which is below 2 in an observational study, you have to be very cautious before taking a general conclusion. So based on E3N study results and even the Women Health Initiative study result, which is a placebo-controlled study, we can conclude that if there is an effect of progesterone in the E3N study, or even MPA in the Women Health Initiative study, those effects on the breast are very limited and they are small increase. And I am not sure that a small increase in relative risk in the E3N study with micronized progesterone is clinically meaningful, knowing that this relative risk increase is lesser than 2 in this observational design study. So if there is an effect of progesterone on the breast, it is a very small effect and you need a long duration of treatment before having those positive or negative effect. And it's a never-ending story and an ongoing debate to know if progesterone increase or decrease the breast cancer risk. But we have a lot of experimental data, as Regine was suggesting, showing that we are not giving progesterone just for uterus protection, and there are Mother Nature developed progesterone during the whole life to counteract the effect of estradiol. So there is no reason, I think, to treat menopausal women with estradiol alone therapy. And there are a lot of experts favoring the use of combined therapy, even if the woman has no uterus anymore.
Of course, one of the frustrating things is that we're unlikely to see a huge enough prospective randomized trial to answer these questions sort of definitively. Regine, Ludwig Kiesel asks, are the benefits on the brain of progesterone and estradiol additive in menopause? Do you get a synergistic effect, or are they independent?
Yes, I didn't show some of the other results we had with estradiol. In fact, there is no reversion of the effect of estradiol, which is beneficial as well on myelin repair. And a combination with nesterone that we have tested does not change this response. So with the dose we have identified plus estradiol, we have not really a synergistic effect, but in fact, no negative effect of one on the other. Both are positive.
One of the questions that's been asked by a number of our delegates is, despite all the benefits, Paul, that you have talked about, there are still some women, and I see them in my practice, that have emotional and physical symptoms from using progesterone, PMS type side effects. I'd like you, and perhaps Regine as well, to comment on why some women still, even with all the favorable aspects of progesterone, still seem to have side effects from it.
When I go through all the clinical studies we did with natural progesterone, that's true that in very rare cases, there are some women which are very sensitive to the liver metabolism of progesterone. But, and that's probably the reason why you have some paradoxically side effects in some women taking oral progesterone. But it's certainly not more than 1 or 2% of the women taking the progesterone. And the story about premenstrual syndrome is not so clear, because if you look at the meta-analysis by White, which is the best one probably in premenstrual syndrome, you can see that all progestogens are not efficacious to treat premenstrual syndrome, except when they were using natural progesterone, based on the study we did with Laureen Dennerstein, published in the British Medical Journal. So I think definitely that we don't understand very well, and these are probably a lot of etiologies behind premenstrual syndrome. But that's for sure that I think that the premenstrual syndrome is induced by an unbalance between estradiol and progesterone in the second part of the cycle. So that's true that we have to take into consideration some women which are highly sensitive to the liver metabolism of progesterone, but very rare cases.
Yes, no, I agree. I think it is a heterogeneous group, and you see some that do very well with progesterone and benefit from the calming effects, and others that have a mood suppressing effect, and that could be a genetic predisposition, but it definitely needs more research. So the question then is, for those women, sometimes we use the vaginal route, which you talked about, Paul, and that does seem to be an advantage in women that have CNS type side effects. But we don't, the 100 milligram dose in hormone therapy is not licensed for vaginal use, even though off-label it is being used. Could we ask, because there are data for protective effects, why a license has not been sought for vaginal administration of progesterone, of the 100 milligram dose?
I think that the answer is very clear. To have a license, you need to design an appropriate randomized control trial to demonstrate that the 100 milligram daily dose by vaginal route of administration is protecting the endometrium. And it's very complicated to make such a study, because you need to make biopsies before starting the treatment, and the second biopsy in the same woman 12 months later on in more than 300 patients. So it's not an easy study to do, but there are some convincing data in looking at the tissue concentration of progesterone after vaginal use of progesterone, and we have a lot of experience from the IVF patients. We know that the tissue level of progesterone is more than enough to protect the endometrium when you apply the progesterone by the vaginal route of administration, based on this IVF experience we have and the tissue level. But that's true that to have a license, you need to design an appropriate phase 3 trial. It's expensive, it takes a long time. And but I'm not sure that it's a good idea to administrate vaginal progesterone at the time that in most of the women, the oral route of administration is appropriate for menopausal treatment.
I would add, I mean, and concur with what you say, Paul, because the industry is usually reluctant to invest into reproductive health therapy in general for women and for menopausal therapy. And as an example, I mean, the progesterone vaginal ring, which would be ideal in a way, as you would have it in place for 3 months and you can renew and give stable low level in the blood and good concentration in the tissue, would be an opportunity that no one has wished to develop because of the cost of this regulatory request of having 2 years, 300 women the first year, at least 150 women completing the second year with the biopsies up to 2 years.
Question here from Toby de Villiers. Does digesterone have neuroprotective regeneration effects? And there's also another question as to whether progesterone should be given to men. For Regine, maybe.
Well, I think that the model, to answer the second question, yes, of course. I mean, because we have seen that, as you have seen, even if there is no circulating hormone in ovarectomized models or in male animals, you have this response. And the neurosteroids transformation exists as well. Our first intent was also to use nesterone in men and women with multiple sclerosis. There are other considerations that make it maybe more difficult because of the dose needed. However, I think it could be used, and possibly allopregnanolone will also be used in the Alzheimer model in the future. And the first question for dydrogesterone, I don't think it has been studied. From the very first studies of Roberta Brinton, she tested many progestins, but mostly the 19-nortestosterone derivatives, the MPA, which was negative at all experiments. And we do not have data on the dydrogesterone.
There've been a number of, oh, sorry, Paul.
And I concur with what Regine is saying. And moreover, at the pharmacological point of view, dydrogesterone cannot be metabolized in this allopregnanolone, which seems to be the key hormone to work on the GABA receptor. So, but we know that allopregnanolone can be also converted back to progesterone into the brain. And as Regine was mentioning, in fact, we don't know exactly how it works progesterone or allopregnanolone on those GABA receptors, and those neuro effects are quite complicated, but they are very encouraging data on the stroke prevention, for example. And surprisingly, it was working better in male animals than in female, as mentioned by Michael Schumacher in his studies. So a lot of ongoing debate and a lot of work to be done to understand better how it works. But dydrogesterone, in my opinion, is not efficacious, or there is no data supporting the effectiveness of dydrogesterone on the brain and on the GABA receptor.
In close proximity to the brain, there have been a number of questions on meningioma. We know that there is a link with cyproterone acetate, for instance. Are there any concerns about progesterone or nesterone being linked to meningioma risk?
Well, we discussed this issue at large with Roberta Brinton, and in fact, there is at the same time apoptotic response that regulates the cell multiplication. And it is not that when you give the treatment, it will multiply again. So the specifics of the meningioma is that it's most likely pre-existing meningioma that may be triggered by the treatments. We know that, for example, anti-progesterones have been used to treat meningioma, but the response was not so clear-cut in double-blind studies. So it's still a concern, but it has been seen only with a few molecules, and it has not been seen with others. And where I said there is a different response in terms of stimulation of the BCL2, which is a marker of apoptosis and cell regulation.
There are a couple of questions on transdermal progesterone. The delegates recognize that it isn't sufficiently potent to protect the endometrium as part of a hormone therapy regimen. Paul, would you like to say why natural progesterone cannot be delivered transdermally for this purpose?
I think that there is quite a consensus stating that if you don't reach more or less a progesterone blood level, which is about 3 nanogram per ml, it's difficult to state that your progesterone will be efficacious to protect the endometrium. And certainly if you don't apply the progesterone by the vaginal route, or where you can have a kind of first uterine pass effect, but applying progesterone on the skin, there is not enough progesterone penetration to reach this kind of magic cutoff level of 3 nanogram per ml, which is the level you need to reach for ensuring endometrial protection. I know that there are some formulation in the US or in Australia who are trying to show that progesterone protects the endometrium because there is an increase in the progesterone in the saliva and there is a flow through the capillary system, but that's all hypothetic mechanism. And in clinical practice, I think that all experts and guidelines agree that transdermal is not efficacious to protect the endometrium.
If I may add something, there is a lot of 5-alpha reductase enzyme on the skin, and progesterone is metabolized into 5-beta dehydroprogesterone when it's applied on the skin. Nesterone, for example, which is not converted, can be administered through the skin and is measured in the plasma as in change, as the parent hormone not metabolized. So I think that there is this response in terms of enzyme and metabolite. And as another example, nesterone is being administered in the gel, and it's with the gel you can administer very high doses that what you need for multiple sclerosis. And this was a discussion we had when preparing this first study, still in the works.
There are so many excellent questions coming through. It would be frustrating to terminate the webinar shortly, but we do have a limited time. Perhaps we can finish on the possible use of allopregnanolone rather than progesterone as an alternative in hormone replacement therapy. There's been a couple of questions about that. Any comments about the possibility of using allopregnanolone rather than progesterone?
Well, at the moment, Roberta Britton has synthesized allopregnanolone and is testing and has measured the maximum tolerated doses, because then you have really side effects in terms of sleepiness and dizziness, which is the very effect on the GABA receptor. So according to the dose that she made, it demonstrates to be effective and well tolerated. I think in the future we may consider that, but we need to wait for the efficacy result that she's preparing.
So with that, I would like to say a huge thank you to both our speakers. And I asked them to produce some bullet points to summarize their talks. And these are the bullet points that Paul provided as take-home messages. And they are that natural progesterone has unique pharmacodynamic activity and a safety profile compared to synthetic progestins. I think we've really covered this very well, that a class effect does not and should not exist for progestogens in the way they're referred to in terms of both their efficacy and safety when used in MHT. The extent of activity of progestogens, i.e. on the central nervous system, is not only modulated by the type of molecule and the metabolites, but also by the type of regimen, the daily dose, and the route of administration. And body identical hormones, including transdermal estradiol, and associated with progesterone, is probably the best choice in terms of benefit-risk ratio, it could be argued, when administered in the early menopause for a duration of at least 5 to 7 years. The bullet points from Regine are that beside its well-known action to protect the endometrium, progesterone has an important role on neurogenesis. Progesterone and nesterone, but not MPA, show positive effects on myelin repair and neuroregeneration in stroke models via selective progesterone receptor transactivation. In the Alzheimer's brain model, progesterone acts also via allopregnanolone, interacting with the GABA receptors, and this showed a benefit on tissue regeneration. And the neuro benefits bring new insights on selecting future menopause therapy. I would like to invite you to visit our new IMS website. We're very excited about it. We think it's very user-friendly, and hopefully you will find lots of very useful information on there, and consider joining our society as well. You would be very welcome. And finally, we will continue our monthly webinars right up to our 18th Congress on Menopause in Lisbon, and hopefully beyond as well, which we hope to be at least partially, if not fully, face-to-face on the 26th to the 29th of October 2022. And we look forward, hopefully and finally, to seeing people face-to-face for a change. But with that, we hope that you've very much enjoyed this webinar. We've certainly enjoyed bringing it to you. Thank you once again for our speakers and to BT for hosting the webinar. And we look forward to you joining us for the next one. Thank you very much.